All right, so we're going to get started. Thank you everybody who's tuning in for tonight's webinar. I see some familiar names. Welcome. And very special thank you for taking the time out of your Wednesday evening, or if you're one of our international listeners, on your Thursday morning. My name is Dr. Emily. I am the founder of the Evidence-Based Fitness Academy, and I am a podiatrist in New York City, as well as a movement specialist. So tonight's webinar, Walking Gait Assessment, and we are questioning, is this the most functional movement assessment? This is going to be a little bit of a teaser for a new course that we have through EBFA, which is called Foot Strike and Functional Movement, which is a walking and running gait assessment course that we teach and have several exciting locations already set up for 2013 and 2014. We'll go over those in the end. Tonight's webinar is sponsored by Corey Vines, CoreyVines.com. Very special thank you to them. We have our pop quizzes or flash quizzes throughout tonight's webinar, and those we will be having the opportunity to win some free athletic wear. So it's very nice. I have some of their athletic wear and it's very high quality. So make sure you get those thinking caps on and your fingers ready, because the person who answers the question correctly first will win that athletic wear. So we're going to get started. Again, remember, all of our webinars are archived. They can be found on our YouTube channel, youtube.com/EBFA Fitness. We will go over some questions at the end. So if you have any questions, please know that you can stick around and we're going to go through some of those questions. So without further delay, we're going into walking gait assessment. So if we think about the different movements assessments that we do with our clients, with our patients, we really want to know, what is the purpose behind doing a movement assessment? Why are you watching your clients walk? Why are you watching them squat? And really our answer behind this is that these movement assessments are giving us an idea of the way that our clients and patients move, right? So do they have any joint immobility or hypomobility issues? Do they happen to have any joint stability or instability issues? And then how is that affecting their kinematic and kinetic chain? We want to look at the integrated function of different joint complexes. Now, again, we're talking about walking here, and a lot of the movements that we do happen to be closed chain. So that means we're looking at the integrated function that the foot has then on the ankle, and then into the knee, into the hip, into the lower back, and then it can progress all the way up into the thoracic spine and to the shoulders. So how are all of these joint complexes working integrated? We're also looking at efficient movement patterns. And this is when you start exploring a lot of movement dysfunction, this is the area that I find very interesting. And a lot of this actually has to do with myofascial flexibility, myofascial viscosity. And that's where I'm seeing, from a podiatry setting, a lot of injuries is because of this inefficient movement patterns, specifically in their myofascia. So out of these functional movement assessments, a lot of people are doing squatting, maybe a lunge. Some people do FMS. But do you currently do anything with walking or with gait? If we think about the movement assessments that we're doing, we really want those movement assessments to guide the most functional movement that your clients or patients are doing. So if we think about it, what would you suppose would be the most functional movement that your clients and patients are doing every day? I would suppose that it would be walking. Walking is probably the most functional movement that your patients and clients are doing. And this is actually the functional movement that your clients and patients are doing when they get injured. If you think about it, the average adult takes between 5,000 and 8,000 steps a day. Every time you take a step, you have between 1 and 1.5 times your body weight going through your foot, your ankle, your knees, your hips, into your lumbar with every single step that you're taking. If your client or patient does not have joint stability, if they do not have joint complexes that are working in an integrated function, or if they are inefficient, that's where they're getting injured. They're going to start compensating. They're going to start cheating. They're going to be using their synergistic muscles to try and stabilize these unstable joint complexes. And then again, yes, that is where they get injured. Once they start getting injured, They're going to start decreasing their activity, and then that leads to all of their comorbidities that we are very familiar with. So we're going to explore how we can take the most functional movement that your clients are doing and then assess it and then build your programming off of what you see in that functional movement that your patients and clients are doing 5,000 to 8,000 times a day. So if we look at the functional demands of walking, right? Walking requires a lot of different integrated functions. It's the timing of those muscles, it's the timing of joint stability that allows your clients and patients to move efficiently. So by watching your client or patient walk, you can see their joint stability. It is our joint stability that allows us to adapt to the terrain. So if you had an unstable subtalar joint or an unstable ankle, even an unstable knee or hip, when you walk on a different terrain, you're going to have excess motion in that joint, which then leads to compensation patterns and excess stress on those joints. We're going to look at their eccentric control, or we're going to be able to see their eccentric control. If your client has poor eccentric control in their posterior tibialis, guess what's going to happen when you watch them walk? You're going to see too much eversion or pronation collapse when they shift into that single leg position. As they go through that mid-stance position, you're going to see too much pronation. So you can pick that up and you know right away that there's an issue with their eccentric control. Do they have knee pain? And then you watch them walk and they have increased knee flexion or an uncontrolled knee flexion. Again, that's telling you that they have poor eccentric control. We can also assess their balance, right? So most of our time, 60% of our time when we're walking is actually on one leg. That means that probably the most effective balance assessment would be to watch somebody walk. If somebody can't even walk without balance, there's no way that they're going to be being able to do all these other balance exercises. So again, a great way to assess balance. And then the last one is that we can assess their efficiency in their movements. We can assess their elastic recoil. We'll explore that a little bit more about what that means. Remember that walking is supposed to be very efficient, a lot of recoil and little effort that is going on during the walking gait cycle. So if you're brand new to a gait course or gait workshop, going to break it down a little bit. Again, it's designed to be more of a teaser and lead into our full gait assessment workshop. But again, I want you guys to leave with some great information so you can start looking at your clients and patients a little bit differently. So if we look at the gait cycle, our gait cycle is broken down into two phases. You have a stance phase and you have a swing phase. 60% of your time, or a majority of your time, you're standing on that one leg, so you are in stance phase. The other 40%, your opposite leg is in the swing phase. Our stance phase, again, majority of that time, that's the part that we're going to focus on. That's the part where you're seeing joint stability, integrated joint function, eccentric control, and efficiency is in that stance phase. That stance phase is broken down even further into a contact phase, mid-stance phase, and propulsion or push-off phase. Your swing phase, which again, we're not going to explore too much, but we're just putting it out there, is initial swing, mid-swing, and terminal swing. That whole swing phase is all elastic recoil. So, time for a flash quiz. So get your fingers ready, get your thinking caps on. If you want to win some great athletic wear by Corey Vines. So again, we're going to go over the question. You're going to type it in to the questions box. The first person to answer it correctly will win some athletic wear. Here we go. Which two tendons in the foot and ankle undergo a torsional rotation as they approach their insertion? Which two tendons in the foot and ankle undergo a torsional rotation as they approach their insertion? And you got to get both of them correct. Gastroc and soleus, so that's one. Two tendons, that counts as one. Sabrina Merrill, good job. Posterior tibialis and the gastroc and soleus. So Jennifer Barlow and Sabrina, congratulations. You got it correct. We are back. We are into our stance phase. Now remember that this is 60% of your gait cycle. Okay, again, 60% of our gait cycle. We can further break this down into initial contact. We'll call this heel strike. We then immediately have a loading response. As soon as you strike the ground, something is happening in your body to react to that ground reaction force of 1 to 1.5 times your body weight. That is called the loading response. We then transfer into a single leg stance, which is called midstance. We then transfer as our body weight shifts forward into what's called late midstance. And then we end with our propulsive phase or terminal stance. So again, we're going to go through each of these. If you watch your client and patients walk, you should be able to catch each of these different phases, record them, upload it, and run it on your computer slow motion, and you can see every single one of these phases. And we're going to see specifically what you want to see in each of those phases. So we have heel strike, initial contact. We strike the ground on the outside of our foot. You want your foot to be in the most stable position when you strike the ground. Foot stability comes from subtalar joint inversion. So you want to strike the outside of your heel. Your heel, when your heel is inverted, your foot is then stable, right? So that's our association. Inverted foot equals stable foot. If your client is striking the inside of their heel, right, that means that they're striking with their foot in an everted position. If your foot is in an everted position, that means that your foot is unstable, unlocked, and hypermobile. If we remember from maybe some of the courses that we've taken, or if you've ever taken any of the courses from EBFA, is when your heel is in an everted position, that means that you start getting this joint coupling where your tibia and your femur are internally rotating. This increases the stress to your anterior knee. So again, striking the ground with your foot unstable or everted is going to internally rotate your tibia and destabilize your knee joint. Now you got a lot of forces going through that knee joint, and your client or patient is going to complain of pain. And it probably would be apparent when they're doing squats and lunges and a lot of the regular exercises that you want to do as part of their program. So if you can catch this in their gait assessment, you can know that you need to address that foot and that subtalar joint. So foot types and the impact. This is all about the subtalar joint and our foot position. If we look at the picture on the left, we have an overpronated foot. If we have the picture on the right, that's an oversupinated foot. So if your client or patient deviates to either side of that foot position, they're too everted or they're too inverted, neither of those are good. Every gait assessment should start with a static foot assessment. Look at their subtalar joint. Have them stand in front of you and you're looking at them from behind exactly like these pictures are showing. If your client has a picture like the one on the left, so they're overpronated or over-everted, most likely they're going to strike the ground like this picture, which means that their foot is not stable, their knee is not going to be stable, and neither is their hip or their lower back. If you have the client on the right where they have too much inversion, that's not good either. Just because inversion means stability, too much inversion means a very rigid foot that is not going to react to ground reaction force as well. So if you strike the ground too inverted, just like the picture on the right, you're going to be too rigid. That client or patient is now at risk of Achilles tendonitis, stress fractures, shin splints, and it going up into their knee joint and into their hip. So you really want to look at both of them. You want to find that perfect neutral foot position. Remember that the only contact point between the body and the ground is your foot. So we always have to start with this as our foundation. All right, so we just struck the ground, heel strike. We now have 1 to 1.5 times your body weight going through your body. So it is time for the loading response. This is where your body begins to initiate shock absorption. The way that your body absorbs shock and stores that shock as potential energy is through eccentric contractions. Again, eccentric contractions is how your body loads impact forces and stores those ground reaction forces as potential energy. So if we look at this ground reaction curve that's on the bottom here, right, we see two curves. That initial peak that we have, that is heel contact, right? Then we see that rapid decrease, right? That rapid decrease after initial impact, that is where you're doing eccentric contractions. That is where your body is storing energy for the last phase where we do elastic recoil. So the muscles that are contracting eccentrically, there's a lot. This is where eccentric training should be the foundation to your client's programming if you're looking to optimize their gait. So we have tibialis anterior. As soon as you strike the ground, your heel strikes the ground, your tibialis anterior is firing eccentrically to decelerate the foot from slapping down. Then we have our posterior tibialis kicking in, where that's firing eccentrically to control eversion and absorb shock. Your soleus, which is best friends with your posterior tibialis, is doing the exact same thing. It fires eccentrically to control eversion of your heel. Your quads fire eccentrically to control knee flexion. And then your gluteus medius and upper glute max are firing eccentrically to control internal rotation. And your lower glutes are firing eccentrically to control hip flexion. So this is a lot of stored energy. Remember that gait is all about efficiency and elastic recoil. All of that energy is stored in every single one of these muscles. We need to train our clients to move efficiently by training all of these muscles eccentrically. So we just stored our energy. Now it's time to shift into that single leg stance. Remember that this is where we're testing or assessing our client and patient's balance, hip stability, lumbopelvic hip stability as soon as they transfer into the single leg stance or mid stance. Primary muscle that is activated in this phase is your gluteus medius. So we need stability from our hips to our knees and then into our foot. Your pelvis, as soon as you transfer into that single leg position, you're testing their glute medius strength. So you could do a single leg stance as part of their assessment. You could do single leg squats, or you could watch the way that they walk, and as they transfer into that mid stance in that single leg position, that could also be a great way to assess their glute med strength. We're then going down into our knee joint. Our knee joint, we're looking at transverse plane stability. Remember that as we are starting to load ground reaction forces, your gluteus medius is firing eccentrically to resist internal rotation, right? It's the internal rotation of that femur or that hip that creates torquing or shearing forces into that knee joint. So for transverse plane knee stability, we need to stabilize both from the hip and from the foot. Your knee is one of those joints that's just caught in between two large kind of joint complexes that is easily influenced by either hip instability or foot instability. When you're doing your gait assessment, we need to consider that. So we see our transverse plane knee. We have the client over here on the left, right? We can see that they have this valgus. If we follow the femur down and we look at the patella, we can see that the angle is going onto the inside of the foot. This runner, their foot is angulated in an abducted position, which means they have a valgus strain going on in their knee joint. So if we think of the muscles that are resisting excessive internal femoral rotation, right? That would be those glute maxes and the upper gluteus medius. We need to strengthen those. We're assessing their strength, their ability to function dynamically. On the bottom, from the foot up, what is resisting excessive internal tibial rotation, right? These muscles here that we're also assessing during gait is your soleus and your posterior tibialis. So a walking gait assessment is assessing hip strength, gluteus medius strength. It's also assessing the foot strength, specifically in the post-tib and the soleus. Finally, we're going down into that foot stability. We have frontal plane foot stability that we're assessing during gait. This is where we're seeing the balance between our inverters and our everters. Okay, so we need to, optimal foot function requires a balance between the inverters and the everters. All of your inverters lie on the inside or the medial aspect of your subtalar joint or your foot. All of the everters insert on the lateral or outside of the foot. So we have our inverters, right? We have our tibialis anterior, our posterior tibialis, our soleus, and then one intrinsic muscle, which is your abductor hallucis. These four muscles are your frontal plane foot stabilizers in that inverted position. All of these muscles counter the muscles that are on the outside, which is the peroneal brevis, peroneal longus, and gastrocnemius. So during your gait assessment, you are assessing their frontal plane foot stability dynamically and under impact forces. So again, we want to get our clients and patients not just doing squats and lunges, but we want to get them dynamic, and we want to see the way that their body reacts to impact forces, because that's where they're getting injured. Finally, we're transitioning into late midstance. Right, so again, late midstance. This is where we get our peak potential energy. This is the point of gait that you need maximum ankle joint mobility. Maximum ankle joint mobility is required at late midstance. The reason that this is the phase of gait that you need maximum ankle mobility is because this is the point that your body is putting the greatest stretch on the Achilles tendon. The Achilles tendon not only is the largest and strongest tendon in the body, but it is the tendon, or the one tendon in the body that has the greatest elastic recoil. That's why it's positioned where it is. It plays a functional role in efficient movement patterns. So if we do not have enough ankle joint mobility, we have restricted mobility in our ankle, your clients are going to cheat, right? This is one of the biggest things that we can pick up. If you do a squat, you have your clients do a squat, they pop their heels up. Maybe they knock their knees in. Maybe their feet turn out. Maybe they drop their chest. These are all compensation patterns for limited ankle joint mobility. But that is not a dynamic assessment of the way that your client or patient's ankle is moving under impact forces. This way, by watching a gait or doing a gait assessment, you can catch and see the point in gait that they need maximum ankle mobility. If their heel is popping up too early in gait, guess what? They have limited ankle mobility. If I look at them in the front, like this picture on the left, and I see late midstance, which is where this subject is at, and they're pronating. Pronation is a compensation for limited ankle joint mobility. So we know that this subject here has limited ankle mobility because the point in gait, which is what this image is showing, where we need maximum ankle mobility, they're cheating. They're pronating and everting their subtalar joint. So again, two great ways that you can pull out a lot of information. Finally, we're going into the last phase, which is terminal stance or propulsion. This is where we start to release all of that stored potential energy. This is where we shift into the front of the foot. We're preparing for push-off. Now we're involving another joint. The joint that we are now involving is our great toe. So now this is a great way to assess your client and patient's great toe mobility, which is critical to optimal gait. Your clients need at least 30 degrees of dorsiflexion in that great toe joint to walk properly. If they do not have enough dynamic mobility in that joint, they're going to cheat, which means that they are either going to shorten their stride, become apropulsive, pronate, turn their feet out, and guess what all of those compensations do? Is they lead to further compensations. They start to lead to joint uncoupling. They stress more proximal joints, and they lead to injury and inefficiency. So again, great toe mobility, a great way to assess that dynamically is through a gait assessment. Finally, we're going again, elastic recoil. So this is where we're getting all of our efficient recoil. So if we look at the picture here, the picture on the left, we can see that they're starting to dorsiflex their great toe. When you dorsiflex your great toe, you're going to put tension on that plantar fascia. That plantar fascia originates on the inside of your heel, so you're going to start to invert your foot. The foot is nice and rigid. Your plantar fascia is part of your Achilles tendon. We're starting to plantar flex the ankle, which means you're now releasing all of the energy that was just stored in that Achilles tendon during late midstance. You're starting to then extend your hip, which is going to swing forward out of that elastic recoil, and then that is your efficient movement. So again, terminal stance, propulsive phase, this is where you're unleashing all of that elastic recoil, but your ability to release that elastic recoil is greatly dictated by that great toe. All right, so we have another quiz. Again, we are sponsored by Corey Vine, so if you want some athletic wear, get ready for your quiz. The windlass mechanism is the activation of what soft tissue structure? The windlass mechanism is the activation of what soft tissue structure? Anybody know? Excellent job, Ellen. It is the plantar fascia. So the windlass mechanism is the activation of the plantar fascia when you dorsiflex your digits. When you dorsiflex your digits and you put tension on that plantar fascia, you begin to invert your subtalar joint or your heel, and that makes your foot into a nice rigid structure, which you can push off of. That is your windlass mechanism. Again, congratulations. All right, so now we're going into the programming. So again, to recap, right, we have the gait cycle. We have 60% of our time in the stance phase. Your stance phase is broken down into heel strike. We want to heel strike in an inverted position. As soon as you strike the ground, your body is preparing for this loading response. Your loading response is where you store all of those impact forces as potential energy, which will then be released later in the gait cycle. The muscles that fire eccentrically is your tibialis anterior, your posterior tibialis, your soleus, your quads, your glute medius, and your glute max. So it is foot eversion, ankle dorsiflexion, knee flexion, and hip flexion, which is how your body stores energy. We then transfer into midstance, where we stand on one leg, and we get a lot of balance and stability required from our gluteus medius. We then transfer forward into late midstance, where you put the greatest amount of tension on your Achilles tendon and get your peak storage of potential energy. As that leg swings forward and you start to dorsiflex your big toe and plantar flex your ankle, you now begin elastically recoiling and releasing all of that stored energy. So we assessed our client, again, got the basics of what the gait cycle involves, the position that the foot should be in, and the type of muscle contraction that is happening at each phase. We're going to go over a couple examples of the way that you could start to design programming based off of what you see. So we have the client who is striking the ground overly inverted. Remember, if you strike the ground too inverted, that's not good either. An optimal degree of inversion is what you want. If you strike the ground too inverted, this means that your foot is now overly rigid. You're not going to adapt to terrain well. Your client is going to be at risk of stress fractures, Achilles tendonitis, plantar fasciitis, ankle sprains, ITB issues. Right? So we want to loosen them up. If you work with any marathon runners, any runners, and they're striking the ground too inverted, they're increasing the risk of injury. So you watch their gait, you notice they have too much inversion. Start to design the programming to mobilize that foot. Mobilize that foot and get them to release that subtalar joint. Get them into a more neutral position. Release their soleus, their tibialis anterior, and their soleus. You want to strengthen or challenge their ability to respond to impact forces. So you are doing eccentric training to the quads, the glutes, the post-tib, and the soleus. Okay, so that's how we're going to begin designing this client or patient's programming based off of their gait assessment. We have another example. We see that our client or patient is striking the ground everted or on the inside of their foot. You're watching them, you're behind them on the treadmill, and you notice they strike the outside of their foot. So you now know that their foot is hypermobile and unstable. Anytime the foot is everted, the tibia and the femur are internally rotating. So now you know they have too much internal rotation, so they probably have poor transverse knee stability, which means they will probably complain of knee pain or patellofemoral knee pain. They have uncontrolled pronation, which leads to shin splints. Uncontrolled pronation or eversion leads to posterior tibial tendinitis. So if this is what you're noticing on your client or patients, what you need to do is start stabilizing that foot by strengthening the posterior tibialis, the soleus, the gluteus medius, the upper glute max, and start getting that foot into an inverted position and start to derotate both the tibia and the femur. Okay, so again, ideal position is striking on the outside, not on the inside. This client, again, is at risk of knee issues, shin splints, posterior tibial tendinitis. If this is the way that they're walking, imagine the way that they're jumping, and imagine the way that they're probably squatting as well. So you can pick up this exact same thing without ever doing a squat. All right, so now we're looking for that early heel lift. So we're no longer looking at our clients from behind. We're looking at them from the side. So what we're seeing is when they transfer into that late mid-stance position, if they're popping that heel up too early before their opposite leg even gets close to the ground, they have what is called an early heel lift. This same client would probably do their squats and pop their heels up or drop their chest. So this early heel lift, what that means and how that impacts gait, that means that they're not getting that maximum stretch to their Achilles tendon, which means that they are not getting the maximum storage of potential energy. This client or this patient does not move efficiently. That means that they do not have as much elastic recoil, so they have to pull their leg through the swing phase instead of it swinging through an elastic recoil. So again, much more inefficient. So if this is a runner and they've ever had an injury, a history of Achilles tendinitis, right? Anything in the anterior hip, this client is overusing their anterior hip because they are activating their psoas and their adductors too early in the gait cycle. So what we need to do, mobilize that ankle. Find out, is there limited ankle mobility due to a bony block, short Achilles tendon? Is their gastroc tight? Is their soleus tight? You got to figure out what is limiting that ankle and then optimize their ankle mobility. Another client that we have is our knee dysfunction. So this is a very common one that I see. Yes, the knee valgus that we have on the left, right? So we have too much internal rotation of the femur on the left, which means we need to strengthen the gluteus medius, right? What's even more interesting and what I challenge you guys to look for when you're doing your gait assessments, and you can start doing your gait assessments now. Just grab your iPhone, have your client on the treadmill, and you're standing in front of them, to the side and behind. Upload it onto your computer and then go slow motion and try to watch the way that their foot is striking the ground. Find the loading response, find the late mid stance, and then bring it through the swing phase. And you'll learn a lot. So right here, the picture on the right, that knee is facing forward, but that foot is facing out, right? So the knee is forward, but the foot is facing out. This is what's called tibial femoral external rotation, and I see this a lot. So your clients are walking with an abducted foot, which means that they're going to roll into the inside of their ankle and stress all of those structures. Every time they push off, they're going to roll into that ankle, push off at the side of the big toe, and internally rotate that knee joint. So this is a very unstable position, which means that these clients are not moving efficiently and have a very high injury risk. These would be the clients that when you tell them to squat, they're always turning their feet out. They cannot squat with their feet in parallel without it hurting their knees. which means that they have too much internal rotation of their femur and an external rotation of their tibia. So again, want to look out for that. The muscles that really lead to this tibial-femoral external rotation is the TFL, lateral gastroc, and the bicep femoris. So think about that, mobilize those, try to get that tibia and femur joint into that neutral position. Okay, so it's a new one that we're going to look for. Now we have two more. Second one, or second to the last one, is in the hip. So you notice, you're looking at your client walking in the front, you notice that they're almost walking on the tightrope or a beam, right? There's a ideal foot position when we walk. This sample on the left, that client is walking too narrow, which means that as they're bringing that leg forward through that swing phase, their foot is striking in an adducted position. This means that their adductors are overactive. If they have too much adduction as they're striking the ground, it is most likely that they're going to have too much internal rotation as well, and they're going to be compensating for some reason that their psoas and their other hip flexors are not working. So anytime you see an overly adducted gait, make sure you're assessing that anterior hip and that glute strength. Last one that we're going to go over is Trendelenburg. So again, as we transition into that single leg stance or that mid stance, remember this is where we're getting our maximum gluteus medius activation. This is the foundation of why you train your clients on one leg, is so that when they're walking, they have optimal hip activation or glute medius activation to stabilize them in gait. This gluteus medius will stabilize that pelvis, it's going to stabilize that knee, and then it keeps going down to stabilize that subtalar joint. So this is critical to look for glute medius weakness. What you would see in your clients who do have glute medius weakness is they're going to drop that swing leg down. If they get a drop in the pelvis of the swing leg, that means that their standing leg gluteus medius is weak. Okay, so again, if the swing leg, as it swings through and that swing leg drops down, that means that the standing leg gluteus medius is weak. You can further test it by having them then do a single leg stance, single leg balance, do a Romberg, and then assess that way as well. So we want to strengthen here. The middle fibers of the gluteus medius is the one that's activated as you stand on that single leg. So we have our last quiz, again sponsored by Corey Vines, if you want to win some athletic wear, and then we'll do some Q&A, some questions. Remember that this is just a little bit of a teaser to lead into our full 6-hour course, which is foot strike and functional movement, where we go through a little bit more detailed on the gait cycle, again walking and running, and then you actually learn how to conduct or perform a gait assessment and then interpret what you're finding in that gait assessment. So last quiz here. The short foot exercise strengthens the abductor hallucis muscle. This muscle supports which bone in the foot? So again, short foot, awesome exercise for the abductor hallucis. This muscle supports which bone in the foot? And we're going to type in our answers. Still waiting for a correct answer. Abductor hallucis supports. Excellent job. So we have Taylor who won. Your abductor hallucis supports your navicular. Great job. All right, so some other great workshops. Again, check out the EBFA website, ebfafitness.com. Remember, all of our webinars are archived and can be found on our YouTube channel, youtube.com/ebfafitness. And if there are any questions about gait, there is some great gait technology which you can get different apps for the iPad and for the iPhone, which I encourage you to check out. Okay, so any questions that we might have? So again, we have our foot strike and functional movement workshops coming up November in New York City. We have November in India, and then we have February in San Francisco. So if you're interested in learning more about the Gait Assessment, definitely tune in and check out if there's a workshop coming up near you. All right, so here's a question. Do you tape the foot in a better anatomical position prior to training exercises? Yes, I do. I use more of the kinesio taping. And the one that I like specifically is their Valgus taping. So for a client who has too much internal rotation of the tibia and too much internal rotation of the femur, I will do then a valgus taping to then get them proprioceptively aware of that proper lower extremity alignment. That's a big one that I do. And then any of your taping, I know some people do a McConnell taping to the navicular. You can do that as well, and then you'll get a little bit better post-tib firing. Short foot is the foundation of pretty much every movement. So there are some tapings to hold the foot into that short foot position. So I do definitely do the taping. Do I ever make it out to the Midwest? Yes, I do. I'm actually going to be in Minnesota in February, and then in Chicago in February as well. So Minnesota and Chicago in February 2014. Can you give an example of the exercises for eccentric control of the quads and glutes for the inverted foot? I do a lot of walking backwards on a treadmill, walking or doing a elliptical backwards. So whatever cardio that your client or patient likes, I have them do it backwards. So training the body backwards trains a lot of the eccentric contractions, and then doing a negative step off. So instead of stepping up on a box like a plyo box, I'll have them focus on decelerating how they're coming down, doing a deadlift, like a single leg deadlift. When you're rocked forward in that deadlift position, that's where your glutes are firing eccentrically. So that's an awesome one for the glutes, eccentric contraction. And then again, you're coming down in a single leg squat, but you're really focusing on the knee alignment and the quad activation. So that would be where the quads would be firing eccentrically. Client recently had the big toe fused. Oh, that's a good one. How is this going to affect her gait and balance, and what can you do to help? That's a very good question. So if we need at least 30 degrees of dorsiflexion of our great toe to push off, right? A lot of those clients actually become either apropulsive or they're going to start to shorten their stride. So that would be if you see that client is starting to compensate or they're shortening their stride, maybe they have underactive or inactive glutes, I almost guarantee that it's coming from that big toe. And what I do for patients like that I also see that their glutes are inactive or underactive, is I put them in a rocker. So you could have them in a rocker shoe. Doesn't have to be Skechers or one of these kind of commercialized rocker shoes, but even a 4-foot rocker. And what that's doing is that's reinforcing that sagittal gait so that they can get enough hip extension to keep those glutes active, because otherwise they're just going to keep shortening their stride. They're going to compensate. You don't want them to turn out. So that's the biggest concern, is you don't want them to just start shuffling or picking up their feet or turning out as a compensation. So unfortunately, and I do that surgery because sometimes there's no other choice because their joint is completely shot and it's almost fused on its own. So then you just kind of do a full fusion. And those patients I like to get in a 4-foot rocker. Do you check for pelvic obliquity when you see a gait abnormality, especially when you suspect or see a leg length discrepancy? Yes, 100%. Anytime you see anything asymmetrical, then you got to be thinking of these leg length discrepancies, which is a great question, and something that I really emphasize in my workshops is asymmetry. That's what you're looking for. If you see one foot that's turned out, and we actually see that a lot, that they're creating these functional limb length discrepancies based off of how they're walking. And the way that they're walking is driven by whatever posture it is that they're doing at work, or how they drive, or how they sleep, leads to these imbalances. So yeah, 100%. Anytime you see anything that's unilateral or asymmetrical, then you got to dig deeper and look for either a limb length, or this pelvic obliquity would then be a functional limb length discrepancy. How do you train barefoot clients with pronation, limb length discrepancy, etc.? If these issues are uncorrected during the exercise, does this put them at greater risk for injury? So if a client has, that's where I do the taping. That's where I would do a lot of the taping. So if a client has too much, or they're overpronated, but I want to get the barefoot stimulation, the taping is perfect. Some clients who get or have this unilateral navicular drop, which means they don't just have a flat foot, but it's almost like the whole inside of their foot is kind of pushing out or bulging onto the inside. Or it's almost like they have a second ankle bone that's in the middle of their foot. Sometimes I have patients who say that. For them, you either need to start with short foot exercise and train them to get that navicular to pick up, and then they'll start firing the right muscles, or you have to do some sort of taping to then hold that navicular up, so then the muscles can start firing. That would be the better option than putting them in orthotics and doing the training that way, if your goal is to stimulate through barefoot science. So that's where you want to really look at what is your objective. If it's barefoot science, doing the taping, awesome way. If it's just to get better kinematic alignment from the ground up, then doing it in orthotic would be fine. If they have a limb length and it's structural, you want to make sure that you're not doing more harm than good. So you want to correct whatever that structural limb length issue is. And then when they're doing the barefoot training, right, there's a lot of ways that you can get a heel lift and have it be on the heel, right? So it's almost like you're taping it into the heel, and then you're doing the training that way. And I've actually seen gymnasts, so the gymnasts would have the heel lift taped to their heel as they're doing their different events and having their training. So there is still a way for your client or patient to have structural issues and then sneak in that barefoot science. And a lot of it is some of that taping. So excellent question. All right, so any other questions? We'll do a couple more questions, and then I greatly appreciate you guys tuning in. So we'll do last question. I have a client that seems to lack dorsiflexion in one foot, almost like the foot flops a bit in the swing part of gait. Toe turns out, hip swings through. The foot flat. Okay. Yes. So as this client, this is my understanding, as the client is swinging the leg through swing phase, the foot is probably dropping down, is what I'm guessing. Suspecting nerve damage. Yeah, I would suspect that as well. Most common nerve that is damaged in a lot of these strokes and kind of idiopathic neuropathies and low back issues is unfortunately the one that feeds the tibialis anterior. So then that would affect their swing phase. Some of these clients have issues, and you want to know is there issue in the concentric phase or the eccentric phase, right? It's possible that it's just in one of those phases, and then you want to train that specific phase. If you feel like if they're tripping, right, and maybe they complain that they trip, or if you have not asked this client if they fall or trip, ask them. A lot of these weaknesses in concentric tibialis anterior, like a floppy foot when they swing through, these clients will say that they trip or they fall. So then when you're doing that, you want to focus on activating as much as you can. Activate the tibialis anterior and then do concentric exercises. Watch them walk. They may have a foot slap and you've never noticed it because maybe you haven't looked for it. So look for a foot slap. That would tell you if it's eccentric, an uncontrolled eccentric phase. If they do drop their foot during the swing phase, that would be the concentric phase. If it is a true nerve damage, then it's a little bit more difficult, and then you'll have to do some bracing for sometimes for these for these clients, but you want to get them in a brace because they're going to cheat over and over 8,000 times a day when they walk. And then they're going to throw out their hips, their QL is going to be overactive, and it's going to lead to a lot of compensations. So that's a very good question. All right. Thank you guys so much for tuning in. Thank you for the great questions. To those who won some Corey Vines athletic wear, congratulations. And if you, again, want to check out some of our archived webinars, please check out youtube.com/EBFA Fitness. We have a great webinar coming up in August, and I can't believe it's already August, end of summer, but we have a great webinar in August with Kevin Moore from Hong Kong, who's doing another great webinar with us. So I wish you all a wonderful evening, or if it's morning over there, have a great day. Thank you guys again, and I will see you next month.